Great. I think everybody's lines are muted, which is great. Thank you all for coming to this webinar on sexual and gender minority participation in clinical research. My name is Mitchell Lunn. I'm an assistant professor at the University of California, San Francisco. I'm also an affiliate faculty member of the Center for Vulnerable Populations at the Zuckerberg San Francisco General Hospital and Trauma Center. And I co-direct the PRIDE study, which is a longitudinal cohort study of lesbian, gay, bisexual, and transgender people in the United States. And I am also the principal investigator of PRIDEnet, which is a participant-powered research network of sexual and gender minorities across the country. So this is a webinar that's produced in coordination with the O2 Overlap study and is which was awarded to the COPD Foundation in conjunction with the American Sleep Apnea Association. So really great to be here. So I'd like to start by really telling you a little bit about who I am. My name, again, is Mitch. I use he, him, and his pronouns. I am a gay cisgender man, and we'll talk about some of those terms in a little bit. I can be a fast talker, and for those of you that are live tweeting this, you can see some Twitter handles there, although some of you may be joining via Facebook Live. So I have no relevant financial or professional conflicts of interest to this presentation. I've received funding from the National Institutes of Health, as well as the Patient-Centered Outcomes Research Institute, or PCORI, and as I mentioned, I'm employed by the University of California. So today I have a couple learning objectives to go over. One of them is that I hope that by the end of the day you'll have a little more knowledge about some terminology related to sexual and gender minorities. You'll understand some of the historical and current context underlying that stigma and discrimination in medicine and in research, and this really involves a variety of health and healthcare related disparities. We'll discuss the patient experience in the healthcare setting for LGBT people, some strategies that you can use if you're any researchers on the presentation today about how to welcome sexual and gender minority people into your research studies, as well as a particular resource that is available for researchers. So we'll really go through those kind of as 5 different modules or 5 different sections in today's presentation. And so let's get started by discussing terminology. And one of the things that I oftentimes like to start with is helping to differentiate between gender and sex. And so many of you have seen sonograms like this of babies. They're used to obviously make sure the baby's healthy, and they're also used to determine the sex, right? If there's kind of dangly bits between the legs where the arrow of boy is pointing to here, we say that you're having a boy. When really, we're actually talking about sex, which is, the biological or physiological characteristics that define the way somebody looks, their phenotype, right? Somebody as a male or female. And, we typically now differentiate sex from gender, which is, more these socially constructed roles, behaviors, activities, sometimes the way people dress, that is what society defines as more masculine or more feminine. And so we typically, I think many of us use the terms male and female to differentiate the sex of somebody, and use the terms man, woman, or as we'll hear about others, to differentiate gender. So it's just important when you're thinking about the language that you're using, whether you're talking about sex or whether you're talking about gender, and that will become hopefully a little bit more clear in the next slides here. When we think about sexual orientation, I think a lot of us think of it as just the people that we're attracted to or the people that we have sex with, but really we kind of we think of 3 different elements to sexual orientation broadly. One of them is, of course, the people that we're either emotionally attracted to, romantically attracted to, those sorts of things. So the attraction is a component of it. Additionally is behavior, the people that we actually have sex with, and what their genders are. And then whether or not what our identity is. Do we identify as gay? Do we identify as straight? Do we identify as bisexual, etc.? And all of these are all components of sexuality, but they don't necessarily necessarily need to be congruent. For example, there's been several studies of men who identify as heterosexual, who may be attracted to people of all genders and may have sex only with other men. And so these, are all components of sexuality. And so it's important to think about what you're actually assessing when you're talking about sexual and gender minority participation in research. And so really, this really boils down to a set of multifaceted identities, and it's important to suss them out when you're thinking about LGBT health broadly. So some of us use this cartoon called the gender unicorn because it helps separate these a little bit better. So gender identity, again, is how people identify, whether that's more as a woman, more as a man, or another gender. And that's different from the gender expression, these green dots along the edge of the unicorn here. And that's how the unicorn presents itself in society. It's more masculine or feminine. And these these two elements of gender identity and gender expression are actually different from the sex that was assigned to the unicorn at birth. In the United States, you can only have male or female on birth certificates, but there is intersex, which we'll talk about a little bit of later, as both a sex that can be assigned in some countries, as well as an identity, and we'll talk more about that in the following slide here. And then these are different from some components of sexuality, right? Who somebody is sexually attracted to, who somebody is romantically or emotionally attracted to, as well as behaviors that they're having. So really these are, at least 5, if not 6 or 7 different components of sexual and gender minority people, and really are components of all people. Some of us just have minority identities. This can be a little confusing. And so the little mnemonic or statement that we oftentimes use is sex is what's between your genes, depending on how you want to spell it, and gender identity is what's between your ears. An easy way to differentiate between sex and gender, because it's oftentimes hard to remember everything. The other way to present this, which I think we're oftentimes moving to because the cartoon is a little trivializing in a way, is this gender abacus, which is that anatomy, gender identity, gender expression, and attraction are all 4 different unconnected categories here that are all on spectrums, right? So you can have the gender identity expression partially be over here most of the time, 6 or 7 of these beads over here, and a couple other ones on the masculine side. And so it can kind of be everywhere, and it depends on context and lots of situations. But I think the key to emphasize here is these are all independent items that don't necessarily relate to each other. And so somebody could have female anatomy, identify as a female, present themselves as very masculine in the world, and be sexually and romantically attracted to men, right? Any combination and permutation here is indeed possible. And so I think many people have probably heard the acronym LGBT for lesbian, gay, bisexual, and transgender. Some of you may have also heard that there's a variety of other letters over the past decades that have been added: LGBTQ, LGBTQIAA for queer, questioning, intersex, allies, and asexual. There's, actually many different ones, that are relevant here. And because there are so many different aspects, it has really become a big alphabet soup. And that can be confusing for people to keep up with all the acronyms. So academic medicine has come up with this term sexual and gender minorities. It's this umbrella term that is really used to describe people who are not heterosexual and who are not cisgender. And we'll talk about what cisgender means, but this is really an umbrella term to describe all of these people. So I use LGBT, LGBTQ, and sexual and gender minorities, or SGM, interchangeably during this presentation. And so feel free to just recognize that as I go forward. So that this, just to clarify some terminology, sorry to harken back to the days of organic chemistry, which people probably were not interested in having today. But cisgender, the prefix cis means on this side of. And so if we think about people, it often describes people who are not transgender. And so thinking of the cis and trans molecules in organic chemistry, remember, for those of you that have taken it, that that the kind of the alkyl groups, or the groups on the end of this molecule, are on the same side. And so you can think of them as your sex assigned at birth as one of them, and your current gender identity. And you can think of them as being congruent on the same side as each other. Where among the trans molecule, the sex assigned at birth and gender identity is on opposite sides, or a little incongruent or discongruent. So that's kind of, we've heard the term transgender, but the term to describe the people who are not transgender is cisgender. And then thinking more about gender identities, there's, now people who don't, there have been people like, forever about this, but it's becoming now more visible, that identify as non-binary or gender non-conforming. And these are folks who may, their gender identity or the way they express themselves, their expression, may fall outside of the traditional kind of man-woman binary. And they may identify as both gender, no gender, etc. There's a variety of terms that you can check out at this website here from the UCSF LGBT Center. I mentioned on a previous slide that I would talk about intersex, and intersex typically refers to a variation in chromosomes or gonads or genitalia that don't fit into the typical male-female sex definitions. This includes a variety of differences of sex development. For example, people that have XY chromosomes but have female genitalia, variety of endocrine conditions like congenital adrenal hyperplasia. And it largely deals with biological characteristics, and it is not related to somebody's gender identity, right? This, again, is another separate, independent category. These folks, because they have, for example, XY chromosomes with female genitalia, in surgery, they oftentimes, or in infancy, they oftentimes get surgeries which in their adulthood they oftentimes state were unwanted, in attempts to normalize them to fit into a male sex bin or a female sex bin. And because of that, they often get assigned a gender growing up and are kind of forced to live in whatever way their surgery was done to fit their anatomy. Intersex is definitely an identity for some people and not a medical condition or a biological difference or anything. But it's important to, again, note that this is not related to sexual orientation or to somebody's gender identity. And we don't use the term hermaphrodite to describe these folks because they're human beings. And so we oftentimes use terms like intersex. The next thing I wanted to talk about was asexual, and this is people who may not have feelings of sexual attraction. This is a sexual orientation. Again, it's not a choice, to distinguish it from celibacy, which is a choice. And in fact, many asexual people, while they may not have sexual attraction, they have romantic attraction, emotional attraction. Some asexual people masturbate, and some asexual people actually have sex with other people. And so it's important, everybody's life is different. And so while they may not have sexual attraction, doesn't necessarily mean that they don't necessarily engage in those behaviors. So again, remember, think of the triangle that I showed at the beginning of sexuality, and that there's identity, which can be somebody's orientation, their attraction, and their behaviors. And so to close out this section on terminology, I wanted to provide just a few principles for thinking about terms, because there's lots of them. I think people get very nervous about using incorrect terms or terms that would make people feel uncomfortable. And so we usually say that there's really no single definition that's universally accepted. Even the few definitions that I've provided today, or the terms about some of that people may be less familiar with, are not the case for everybody. And in fact, they are very dependent on context. The terms that somebody uses to describe their body, their organs, their identity may be very different with their friends versus with a healthcare provider or in a research setting. And so just to be aware of that. We also know that the terms that people use vary in different geographies across the United States. Terms on the East Coast, especially in the Northeast, are different than they are in California to describe certain experiences. And we know that those terms have definitely changed over time. The term transgender was not used in kind of common parlance. You never saw it in a newspaper article, 20 years ago, or very, very rarely compared to today. And so all these things are kind of continuously evolving. Medicine and research likes to bin people into boxes as often as we can for a variety of reasons. And I think my advice here is to avoid doing that if you can, and really to make sure that you ask people about their identities and understanding the difference between identity, behavior, attraction, etc., and use the language that they're using, because that is the best to follow the patient or the participants lead here. So that kind of ends the terminology section. I wanted to move on to discussing how sexual and gender minority people are underserved by the healthcare system. They're understudied in research, and because of that, they're vulnerable to poor health. And so some of the things that we often talk about and get asked are, how many LGBT people are there actually in the country? Why is this even important? That sort of thing. So there's a variety of studies that are shown here. NHIS's National Health Interview Survey. So the blue bars are actually federal or national surveys that are done by the government. And obviously the purple is Gallup, a daily polling agency that polls on lots of things. So this is a variety of data sets, but really anywhere from, 2 to 6% of the US population identifies as LGBT. The behavioral risk factor surveillance system used a question that related to gender identity in Massachusetts, and about a 0.5% of the population identified as transgender. We think that it's anywhere between 0.5% and 1% of the US population identifies as transgender. So if you extrapolate this up to the current US population, we say anywhere from about 8 to about 20 or 25 million people identify as LGBT. More recent data from Gallup actually shows that more and more people over the years are publicly identifying as LGBT. This is not that there's more LGBT people, it's just that there's more people comfortable stating that identity to Gallup when they randomly call 100,000 people a day. You can also see that people who are younger, the millennials, greater percentage of them are identifying as LGBT compared to people of an older vintage. And so it's not, again, not that there's more LGBT people in younger age groups, it's just that they're more comfortable likely answering these questions to Gallup when they get a phone call. So to think about health disparities, I like to think back, to the past 50 years or so, and really recognize that a lot of the health disparities were rooted in stigma and discrimination. And one of them was that homosexuality was actually a psychiatric disorder until it was removed from the Diagnostic and Statistical Manual of Mental Disorders in 1973. In the mid to late 80s and into the 90s, when we moved into the genetic and genomic era, there was the hunt for the gay gene in an attempt to find this quote-unquote mutation and fix it or repair it. That, of course, was unsuccessful, just to clarify, and that there is no such thing as a gay gene. And then there was, at similar times, the advent of conversion or reparative therapy, largely done through lots of religious communities in an attempt to kind of pray the gay away. This has now been outlawed in many states, but not everywhere across the country. We would, of course, be remiss not to talk about the HIV epidemic in the 80s. Many people remember photos like these. And I think the HIV epidemic really ravaged the LGBT community and ravaged many other communities across the country. When this first started to rear its head in our New York Times clipping is from 1981, that it was really met from both the research community and the medical community with hysteria from the federal government and from people broadly, right? Research funders, et cetera. Doctors refuse to take care of people, governments refuse to do anything about it, and it required groups like ACT UP and others to really self-organize and fight for themselves. So this is a die-in in the streets of San Francisco. This is Market Street for people that have ever been to San Francisco, a main street. You can see the trolley tracks that are here and the wires hanging overhead. And really, you know, and protests at the White House, among other places, right? And it took this kind of self-organizing to get the action and help that people needed. And so, you know, HIV is still a big health disparity, and I'll talk a lot about that a little bit more, but I also wanted to share some video, a video and a couple other health disparities that exist. We think that the video is gonna work and play well over Zoom with this many people attending. If it doesn't, I apologize. There will, I think we can make the slides available after, but if the audio is at least working, the message will come across for both of these videos that I'll show today with just the audio. So we'll see how it works. Here we go.
Lesbians do it almost 3 times as much as straight women. Gay men do it nearly twice as much as straight men. And more than 400,000 people die from it every year. In fact, more people die from it than suicide, alcohol, car accidents, illegal drugs, and HIV combined. So what is it? Smoking. It's time to speak up. We have to protect each other. To learn more, visit tobaccofreeca.com.
So this is an ad from the California Department of Public Health. Obviously, he didn't quit smoking right then. I think it's a little contrived and shows that like sex sells is, I think, the moral of the story there. But really illustrates an important point that tobacco and smoking is really one of the LGBT community's largest health struggles. We smoke about 2/3 more than the general population. 1/3 of LGBT people smoke compared to 1/5 of the US population. We spend more than, you know, now this is actually more than $8 billion a year and cut significant number of years off of our lives from smoking. So it's a huge issue. A couple other health disparities that are striking. 41% of transgender people have attempted suicide at one point in their life compared to 1.6% of the general population. If we look at the homeless youth in this category, or in this country, 40% of them identify as LGBT. And this isn't completely surprising. You can imagine that LGBT kids are kicked out of their house for being a sexual or gender minority, or they actually choose to leave their house and become homeless out of concern for their own safety. In San Francisco, we know that the percentage of homeless youth is actually more than 50% because people come here you know, because San Francisco is known to be a safer place for LGBT people. Back to HIV, about 2/3 of infections in this country still happen among men who have sex with men, and that is obviously striking. That number is higher among transgender people and even higher among transgender people of color. And so you can see the intersectionality of various minority statuses. Additionally, the challenging part with all this research is that people are aggregated or lumped together. So we think of transgender women, people who are assigned male sex at birth and now identify as women. They're often kind of lumped together in these studies with cisgender men who have sex with men. So it's you know, not actually assessing the differences between transgender people and cisgender people in HIV risk. The next slide is another video. This one's a little bit longer, but it provides a little bit more information about the effects of sexual and gender minority status on older adults.
As the American public ages, so do lesbian, gay, bisexual, and transgender people. LGBT older adults face the same challenges as other older adults. including financial worries and health concerns. LGBT older adults face additional challenges. Let's compare two women, Tina and Jackie, who were both born in 1947. In 1967 at college, Tina meets Frank and Jackie meets Francis. On a date with Francis after work, Jackie is seen by a coworker who tells their boss. Jackie is legally fired, takes a lesser paying job at a factory. In 1973, Tina marries Frank, but Jackie is unable to marry Francis. In the 80s, Tina and Frank have children, but Jackie and Francis are barred from adopting. After decades of hard work, in 2010, Frank and Francis retire. Tina takes Social Security spousal benefits, but because the federal government didn't recognize same-sex marriages then, Jackie is denied those benefits. In 2015, right before the freedom to marry becomes available nationwide, Frank and Francis die. Tina paid for her in-home care with her Social Security survivor benefits and funds from Frank's pension. Jackie is denied Social Security survivor benefits, and because she was not a legal spouse, is also denied Francis's pension. Their apartment was rented in Francis's name, and her state lacks non-discrimination protections in housing. So Jackie is evicted when she tries to change the lease into her name. Lacking an income and a place to live, Jackie moves into a nursing home and relies on Medicaid to pay for it. She fears discrimination if she shares stories about her past, so she doesn't talk about her life with Francis. Tina can afford in-home nursing care and has the support of her children. After a lifetime of discrimination, LGBT older adults face economic insecurity, poorer health, and reduced support networks. Find out more about the unique disparities facing LGBT older adults and how to remedy them, as well as the strength and resilience of LGBT adults at lgbtmap.org/older adults.
So I hope that shared a little bit of just how stigma and discrimination over time can actually affect people's health as well. And it's really more than just health disparities. I presented a few cases of health disparities, but in actuality, most of these studies where these have been found are actually limited in scope. They're oftentimes done in a particular city or just a particular region, not nationally, and they're limited in the types of study design, oftentimes in very convenient ways, recruiting people outside of bars or clubs or community centers, those sorts of things, not necessarily getting the most robust sample. And so the actual fact of the matter is that most LGBT health-related topics are largely unstudied. Some of them I posed here, what are the effects of hormone use in transgender people? How does that affect heart disease or lung disease or cancer? What are the best screening protocols for breast cancer, for example, in lesbian women who may have never had children, or in transgender men who may have had mastectomies but still have some breast tissue? How do we actually screen that breast tissue for cancer? And similarly, how do social interactions and social networks actually improve people's health? So lots of barriers still remain to answering lots of these questions, and that's really one I wanted to talk about in this next section, which is looking at systemic or institutionalized discrimination for sexual and gender minority people. And the way I like to start this section is as follows, which is that a lot of the reasons that underpin health disparities in the LGBT population are unknown. We don't know why that happens. And the challenge is that most healthcare providers and nearly all research studies don't ask participants or patients about sexual orientation or gender identity. As such, we don't have any data about who the LGBT people are, and all those health disparities persist, or we don't even know what they are, right? We don't know what their underpinnings are, or we can't even identify them in the first place, right? We don't know what we don't know. And to share this a little bit, I wanted to share a couple maps that just kind of demonstrate persistent discrimination. So this is a map of employment laws in the country. Any of the dark green states like California, where I am, actually prevent people from being fired based on sexual orientation or gender identity. I'm originally from Bismarck, North Dakota. So if I lived there today, I could be fired from my job tomorrow because I'm gay without any really legal recourse because of that. So Some states are a little in between the two colors here, Wisconsin and New Hampshire. Those states have protections against sexual orientation, discrimination based on sexual orientation, but not gender identity. And then these three states, Arkansas, Tennessee, and North Carolina, with the yellow exclamation point, are states that actually have laws on the books that prevent the establishment of non-discrimination laws. So it's actually against the law to create a law that prevents discrimination. Complicated, but I think I said that correctly. So, okay. The next one is health insurance. And this is kind of a similar color scheme, which is that I could be denied health insurance in North Dakota because of my sexual minority status, because I'm a gay man. And similarly, if I were transgender and needed transgender medical care, whether it's hormones or surgeries, that could also be denied just because in that state compared to the darker states here. So all of this is to say that there are lots of health and healthcare related disparities, and the National Institutes of Health was starting to get grant applications about LGBT health, and had really needed help defining a research agenda to figure out what to fund. So they actually commissioned a report by then it was called the Institute of Medicine, now it's called the National Academy of Medicine, to conduct a report on LGBT health. And this quote is one that we use often because we think it is it illustrates the need. And that is that the relative lack of population-based data is what presents the greatest challenge to describing the health status and health-related needs of LGBT people. So, I think this is really key. And I'll talk a little bit more about population-based data here going forward. Of course, many people are familiar with the United States Census. The Census Bureau conducts a census every 10 years, and it also conducts what is called the American Community Survey, and that's done in various waves in those intervening 10 years, and it helps provide lots of information about the population of the United States. Sexual orientation and gender identity is not collected at all in the U.S. Census, so we don't know where LGBT people live. We don't know their races and ethnicities. We don't know their incomes, their ages, etc. And it was initially scheduled to potentially be in the 2020 census, but that has now been removed from this subjects plan document. Sexual orientation, not gender identity, will remain in what's called the Census Barriers, Attitudes, and Motivators Survey. And this is really a survey that the Census Bureau does to determine what types or groups of people are actually going to participate in the census or are going to refuse to participate. So interesting enough. There are a few national studies that are done by the federal government, by the CDC. One is the National Health Interview Survey, and in 2013 it added this question related to sexual orientation, which the following best represents how you think of yourself, and you can see that there's kind of a lesbian gay option, a straight option, a bisexual, a something else for people that have other sexual orientations, of which there are many, or I don't know the answer. And similarly, NHANES, or the National Health and Nutrition Examination Survey, has had this sexual orientation related question for a while and attempts to get more population-based data. Of course, the issue here is that there's no gender identity related question, right? This is just sexual orientation, but there does exist a gender identity question. It's more actually a transgender question only. It doesn't really get at what people's gender identity is, just whether or not they consider themselves to be transgender. That exists in the Behavioral Risk Factor Surveillance System, or BRFSS, as it is more commonly called. This is an optional, this sexual orientation, gender identity, or SOGI module is an optional module that is used by some states. Some states actually choose to create their own questions. And as you can imagine, that this is not used by all states, and states that do assess sexual orientation and gender identity may use a different module. Makes it really hard to compare, apples to apples across the country. I did want to share a really exciting new national project, which is the All of Us research program. This is part of the Precision Medicine initiative that started under the Obama administration, and this just launched on May 7th nationwide. It is a federal research program to create a diverse longitudinal cohort to more than 1 million people across the country. We are super excited about this because every single person will be asked sexual orientation and gender identity questions. So you can imagine that the power to actually help improve LGBT health is extraordinary here. Participants can enroll either at a healthcare provider organization like an academic medical center, or they can enroll online at this URL at the bottom. They answer surveys. They actually will consent to provide access to your electronic health records through medical centers. You'll have a single in-person visit that will either be at a medical center if you live near one, or they will send somebody to your house to measure your height, weight, blood pressure, hip waist circumference, a couple other things. And then you'll provide blood and urine specimens. And this is really the first time that LGBT people, sexual and gender minorities, are involved from the beginning in a super large national study. And so we're super excited about it. I encourage people, whether you're LGBT or not, to visit this website and check it out. Because it's a way for everybody to participate. It truly is all of us, and they're taking that very, very seriously. And then finally, to close this section, this I think is a key component, which is that in 2016, the end of 2016, the National Institutes of Health, specifically the National Institute on Minority Health and Health Disparities, officially designated sexual and gender minorities as a health disparity population for research. I think many of us knew this for a long time, but it was great to finally kind of have that formalized. And it opened doors to new funding sources for LGBT health to have this designation. But it really showed, our nation's leading health research firm, the National Institutes of Health, it showed their commitment to addressing sexual and gender minorities. And so it was great to see that. All right. Next, I'd like to talk briefly about the experiences of LGBT people in healthcare and how it affects their participation in research. And so this is data, it's a little bit old, it's from 2010, a survey of about 5,000 LGBT people, as well as people who are living with HIV. And if you just look at the blue and green bars, we're not going to go through each of these graphs individually, but anywhere between 4 and about 20% of LGBT people have had some negative experience in the doctor's office, whether it's being refused to touch them, being blamed for their health status, using abusive language, or actually even being physically abusive. And so these things are obviously deterring to healthcare, combined with the fact that about 50% of LGBT people and nearly 90% of transgender people don't think that there's enough healthcare professionals adequately trained to care for them. So these two things, a negative experience plus feeling like your provider is not knowledgeable, turns people away from the healthcare system, oftentimes never to return, or not to return until very, very late presentations of the disease, because they're, why would you go to a place where you know you're going to be stigmatized, discriminated against, blamed for your healthcare, abused, whatever. So it makes a fair amount of sense. More recent data comes from the 2015 U.S. Transgender Survey, and you can see here that about 1/3 of transgender people have had a negative experience with a healthcare provider in the past year, and 1/4 of them actually decided not to seek treatment out of fear that they would be mistreated by their healthcare provider. And even if we look at psychological distress that interferes with people's lives, of the transgender population who participated in the U.S. Transgender Survey, we see about 2/3 of people said either a lot or some, the top 2 categories of people that had psychological distress interfering with their life the past 30 days, compared to about 1/3 of the general population in the National Health Interview Survey. So these are really, big differences. And then, looking at health insurance coverage among transgender folk, about 25% of them have been denied coverage for hormones in the past year, and more than half of them have been denied surgeries in the past year from their insurance companies. And you can see kind of the breakdown here. And then if we look at health insurance broadly across the LGBT communities, know that about 15% of LGBT people, even in the Affordable Care Act era, of all incomes remain uninsured compared to about 7% of the general population. And we know that that uninsurance is highest among transgender people, with about a quarter of them not being insured. Among sexual minorities, bisexual people are more likely to be uninsured than both gay men and lesbian women. We do know that the Affordable Care Act has had an amazing effect in the LGBT community, and that has reduced the uninsurance rate from 34 to 22% for the people earning less than $45,000 a year. So there's been obviously some huge effects here, but there's still large numbers of uninsured people. All right. So in this kind of last module or last section, I really wanted to discuss how to design welcoming sexual gender minority research studies for the researchers, but also I think this is valid for everybody who's attending, whether you're a researcher or not. And the key point that I want to make is that every single researcher can truly make their studies welcoming for sexual and gender minority people, okay? On a previous slide, several slides ago, I talked about invisibility in research and invisibility broadly, right? Not included in the census, included only in a couple federal studies in more recent years. And in fact, there's the New England Journal of Medicine article about how there are some clinical trials that actually explicitly exclude LGBT people. And so thinking about ways that we can start to counteract this, because this not only improves LGBT health, but improves the representativeness of studies that are not even specific for LGBT health. So the one thing that I like to start with is talking about using recruitment language and imagery. So I mentioned at the beginning that I co-direct a longitudinal study of LGBT people. And so these are images from our website and images that we use in a lot of recruitment materials. And I think the key here is that you can see people of different, people who have different abilities, some people in wheelchairs, we see people of different body types, we see different races and ethnicities, we see people who, have a gender expression that may look like they're transgender, and people can actually see themselves in these images, right? You want to actually have if we did not want diversity in our study in every sense of the word, we would just show pictures of white gay men. And then we would be upset, and how could we be upset when we had no African-American lesbian women, right? Obviously, they would come to this website and not see themselves at all as welcome participants in a study. And so I think that's, a key message is the importance of actually putting yourself in the shoes of all the participants that you're trying to reach, and making sure that they can literally see themselves as participants in your study is important. You can see some additional images here. And here I like to talk about language. And we decided to use language that we know would resonate with our community. And we did that by doing some qualitative work ahead of time, focus groups, market research, talking with people anecdotally. And in all of these ways, we heard that people would participate in a study like ours because they were concerned about improving their own health, but also improving the health of their communities. And you can see that we start here. It's about our communities. It's about each of us. It's about health, and really trying to hit the kind of altruistic effects that we heard over and over and over again for why people would participate. We use language, this is not complex language. We don't even use the word longitudinal. We use the word long-term and other things here to make sure that, by participating in the PRIDE study over time, your story teaches us about these things. So using language that is actually accessible to people of all literacies and all health literacies is really important and an important consideration to think about. Many of us have questionnaires or surveys in our studies, and the two key points that I want to share are that it's important for you to assess gender identity, sexual orientation, and sex assigned at birth on all of your participants. And I'll go in the next slide talk a little bit about why this is important and how to do it. In actuality, your transgender patients, if you have a transgender woman, they may be answering your male-female current questions based on their current gender identity, not the sex that they were actually assigned at birth. And so you're getting perhaps data that isn't necessarily as pristine as you would like it to be. Additionally, it's important to make sure that sexual and gender people can actually answer the questions that you're providing by not actually making assumptions about their lives. Using words like partner instead of husband or wife is important. Knowing that not everybody has a partner and that not everybody wants a partner is important, and that some people may actually have more than one partner. And so important things to think about when designing your survey questions and making sure that people can actually answer them. So I wanted to talk, this is, these next couple slides are probably like the key points that I want to try to get across here today, which are this two-step method for assessing gender identity. And this is work that was done by the UCSF Center for Excellence in Transgender Health, as well as by this consensus group called the Genius Group that was coordinated by the Williams Institute out of the University of California, Los Angeles. And this two-step method is really important. And it involves doing things in this order, which is assessing gender identity first, not their sex assigned at birth, their current identity, right? We're embracing people as they currently identify, not as the sex that they actually may not want to identify with anymore. And when we assess both gender identity and later sexual orientation, then we allow people to select multiple identities. We don't necessarily force people into one box. And you'll see that we need to assess gender identity and the sex that they were assigned at birth on their birth certificate in order to actually identify the people who are not cisgender, the transgender people. And I'll try to demonstrate that here. So let's pretend, for the sake of this situation, that I'm a non-cisgender woman, that I'm a transgender woman. And I get this question: how would you describe your current gender identity? And I note that I can select multiple identities, right? So I identify as a woman, and I also identify with the label transgender. So I'm going to select this transgender woman category, right? I don't actually need this bottom question about my sex assigned at birth to identify the fact that I'm not cisgender, to identify the fact that I'm transgender, because I told you right here by selecting that option. But let's look at a similar scenario. I'm still a non-cisgender, I'm still a transgender woman, but I don't identify with the transgender label. And so my gender identity is a woman. You have no idea if I was female sex assigned at birth or male sex assigned at birth if you don't ask this question. And so you don't know if I'm a gender majority person, a female sex assigned at birth woman, or if I'm a transgender woman, somebody who was assigned male sex at birth and now identifies as a woman. And so it's really important to ask both of these questions in order to fully identify the non-cisgender people. The next thing that researchers can do to increase the visibility of sexual and gender minorities is to include gender identity, sex assigned at birth, and sexual orientation in a table 1 in a research paper. To do this, you have to actually ask people the questions, and so that's obviously key. But doing this actually starts to show, to increase the visibility of SGM people. I typically also say that I list this as sex assigned at birth rather than sex, because as I think, the first slide I showed in this presentation, people conflate sex and gender all the time. They use those words effectively interchangeably. And here they are very different, right? This is the biological characteristics of what you were assigned at birth on your birth certificate, different from the gender with which you currently identify. And so by saying assigned at birth, you signal to the reader and you signal to LGBT people that you actually paid attention to that difference. Other ways to improve your studies are, of course, having culturally competent, culturally humble study personnel. This helps ensure that the interactions that your people on your study have with LGBT people are appropriate. It makes sure that people don't make assumptions, that they use the correct language, that they use the right pronouns that people want to use. I told you at the beginning that I use he, him, and his pronouns. I could use she, her, and hers. And you wouldn't know that if you don't ask me, and understanding the ways to do that is important. This makes LGBT people feel welcome, accepted in your studies, and it also, these types of training actually provide you with strategies to make mistakes, or to rectify situations in which you make mistakes. I make mistakes all the time. I do this for a living, and I still make mistakes with LGBT people. So it's a part of the process, and knowing the ways to kind of recover from those things, because they can be embarrassing, you can feel really bad. All of those things are really important. I think critically is also creating inclusive policies and procedures for your either institution, if you have that capability, but definitely for your research program. And so that's hiring LGBT staff who can help provide some assistance. Of course, the training that we just talked about, providing same gender partner benefits, if that's something that you can control. And I think what everybody can do is display symbols that LGBT people recognize to help increase their visibility. These are a couple of my former and my current ID badge. I have rainbows on each of them, which is a common LGBT symbol. Stanford has recently developed this awesome pin that is like a DNA molecule with some rainbow in there. And Kellen Lord is a LGBT community center in New York City that has these pronoun stickers. So you could write, he/him on here is what the patients do when they arrive in the clinic, or research participants. They stick it on their shirt, and that helps people address them by the pronouns that they prefer. I want to give a shout out and a plea for LGBT community engagement. And this is really the concept of involving LGBT community members, not just as participants in your study, but in really all phases of the study from beginning to end. So looking at how is your research question developed and refined. Obviously, people can participate in your studies, but making sure your recruitment materials are appropriate for LGBT people. Don't just show a bunch of heterosexual couples and expect the gay men and the lesbian women and the bisexual people and the asexual people to come flocking as participants. The data analysis, there may be unique ways for the data to be analyzed that's relevant to LGBT communities. And of course, disseminating it back to the communities is important. We always talk about research that literally lives and dies in medical journals. Academic medicine goes through, we publish a paper, we're all excited, the paper's done. Nobody hears about the results of the study. It's in some journal, which gets downloaded like 50 times and nobody ever hears about it again, right? And so by having LGBT people, and really by having the community broadly, diverse community broadly involved, you can actually create robust dissemination plans and products that actually help reach the populations that you're trying to serve. And think about all those populations, what they may or may not be. As we get to the end here, I wanted to share one resource that's available to people, and that's us, our team at UCSF here, which is made up of staff members and researchers that you can see here, but also a participant advisory board from people across the country. We provide kind of consultant level technical assistance to researchers that are conducting studies. I'd like to note that we help support researchers who are even conducting non-LGBT specific studies. So you're doing a study on COPD, you're doing a study on obstructive sleep apnea, you're doing a study on multiple sclerosis, and you want to make your study more welcoming to LGBT people. We're here to help you with that as well, not just a study about something LGBT health related specifically. So just to be clear, that's an option. And so really to wrap up, I wanted to just say that by including LGBT people in your studies, you can make some really notable impacts and change outcomes. And we talked about the invisibility of LGBT people. And so by starting to include them, you can actually start to identify some of the health disparities and inequalities that we don't even know about, while simultaneously improving the general understanding of health and disease for whatever particular study you're conducting. This overall helps improve the health of LGBT communities, which I showed earlier are known to be have notable health and healthcare disparities, and you're helping to contribute to that increased visibility. By engaging LGBT people as partners and stakeholders in your study from the beginning, you'll really develop a cadre of people that can help you as your study continues to evolve and help you with studies going forward. I think LGBT people have been excluded from things either implicitly or explicitly for a long time, that being explicitly asked to help and improve things in a meaningful way is something that many people find very exciting and are willing to lend their assistance. There are a variety of folks that are part of our team, a combination of faculty members at every stage, from assistant professor to full professors, people of various expertise, from biostatistics to epidemiology to heart disease, to qualitative research methods, of trainees, from undergraduates to medical students to graduate students to residents and fellows. And so this is really a team effort, and I think that's what an important aspect to relate in lots of studies is, that it really truly takes a village, and making sure that you have people at all of those stages is really important. I did not actually calculate on this slide. I'm trying to look. I think everybody, on our team, all except for 2 of these people identify as a sexual or gender minority, and so that's an important aspect that we include, in our approach to things as well. So with that, I'd like to thank a couple folks. Of course, the Patient-Centered Outcomes Research Institute for funding the O2 overlap study, for funding this webinar, et cetera, to the COPD Foundation and the American Sleep Apnea Association for their work with this study and work with me on creating this webinar. We also get support from the NIH specifically for work with the All of Us research program, and have folks at UCSF, as well as the San Francisco General Hospital Foundation. So with that, I will end. Looks like we have a few minutes left for questions, and my email address is available here if people have things that they'd like to shoot me an email about. I'm happy to answer questions that way as well. And so I think the first question, there's a question in the chat box, which I can start with, and then I can take other questions if people are able to unmute themselves, or maybe people can put those questions in the chat box. But the first question is, what do you view as the biggest challenges to conducting LGBT health research? And the answer to that is there are many. It used to be funding, and that nobody would fund this. I think that now has changed. There is now the Sexual and Gender Minority Research Office at the NIH, which is headed by Karen Parker. She has a coordinating committee that has members from every single institute and center at the NIH. On that committee. There's really an LGBT health liaison in every institute and center. And similarly, PCORI, the Patient-Centered Outcomes Research Institute, also has designated LGBT people as a target population. I think the largest one of the largest challenges now is building trust with the LGBT community. They've been discriminated against, stigmatized in healthcare, not just in research, but for a long time. The history of HIV is part of our oral history, right? People that are much younger than me, who were not around at all in the 80s, know about the fact that LGBT people were literally dying on the sidewalks in San Francisco after they got kicked out of their house and refused medical treatment, that people actually literally died, right? That's part of the kind of history of LGBT people. And it includes, it's, not equivalent, but, almost every group has had some horrible experience in the research community, right? Think about Tuskegee or Henrietta Lacks in the African-American community, and there's, poor consent and other procedures that have been done in other populations. So I think it's building trust is a huge one. The most significant accomplishments of LGBT health research, I don't know. I think that there are many, right? And there's more of them that are coming out every every day. I think some of the biggest accomplishments are that we're starting to have increased visibility in federal studies that we can actually start to answer questions. So not the National Health Interview Survey, the All of Us research program, and others. So I think there's some of the biggest accomplishments I think, also would be around the fact of the development of antiretroviral medications for HIV. But I think really a lot of it has been is still to come. The biggest accomplishments are on the horizon. This is really a burgeoning field. So another question is how many people are active in the PRIDE study currently? We have just over, I think, 11,100 or so participants in the PRIDE study. You can go to pridestudy.org and sign up if you're an LGBT person. I tried not to do too much shameless promotion in this webinar about that, but thanks for the question. And it requires no in-person visits. It's an electronic study only. And so that's a way to participate. We ask people, give people an annual questionnaire that takes about 35 to 45 minutes every year to complete, as well as a variety of studies on particular topics that come up over the course of over the year. Any other questions? And how involved is participation in the All of Us research program? Typically, so we don't, it's just started. So people complete 3 surveys, which I think take about a total of half an hour to complete. And they do that online or on their phone. There's an app or on the joinallofus.org website. They also can fill out some consents to link their electronic health records. That doesn't take really much time per se, as long as you're informed about what choices you're making. And then there is a one in-person visit for physical measurements and biospecimen collection, blood and urine. And then over the years there'll be more and more surveys to do. So again, not a huge amount of effort, but still an option. The next question is the Kinsey scale still used in the literature? Not really, to be honest, because that was really only looking, and I actually haven't looked at the Kinsey scale in a long time. I don't remember if it was actually talking about it. It's because it boiled things down into kind of unidimensionality for sexual orientation and didn't look at identity, attraction, and behavior as 3 separate elements. And so people now feel it's a little too simplified to, it does give that spectrum thought, right? That people, that there's on some sort of continuum, but people largely, I think, feel it's a little too simplified for people's identities, and behaviors and attractions to really provide a lot of information. And then next question is, how do you recommend engaging communities which are not largely LGBTQ to have a dialogue around these topics? And I think, people are afraid to actually start having these conversations. And I think the actual point is to just actually start having them. Because there was a recent study that was done at some community health centers where people, to assess whether or not people would actually answer questions about sexual orientation and gender identity, and it was overwhelmingly positive. High 90% percentage of respondents provided that information of patients walking through doors at community health centers. So people are afraid. I think researchers are afraid. Practitioners are afraid they're going to offend somebody by asking these questions. The truth of the matter is that people are used to filling out forms and used to answering questions about their identities. We've asked about race and ethnicity for a long time. We've asked about sex for a long time. That it's almost part of people's expectations to be asked these questions, and these are safe ones to do. The next question is, on a day-to-day basis, how do you recommend someone inquire about an individual's preferred pronouns, whether it's in a clinical setting or a public space? And I think in a clinical setting, it depends on the form that you use or how you assess somebody's sexual orientation and gender identity. When I was a primary care doctor, I would assess people's sex assigned at birth, their current gender identity, their sexual orientation, and which pronouns they use on every single participant that I saw, or patient that I saw. It was part of my new patient visit with them, right? And I have a whole nother talk about how to actually ask about sexual orientation and gender identity, because it takes practice and makes people nervous and gets people uncomfortable. But in actuality, I think it's you just really need to start asking it in a way that's appropriate. And I think we have ways like for gender identity, I would oftentimes say that some people's the gender with which people identify may be different from the way society perceives them to be. Some people's genders can be man, woman, neither, not necessarily fitting into that binary. Can you tell me how you identify? And people would be like, well, all the people who are gender are like, well, I'm a man. And I'm like, okay, great. And then you just kind of move on, right? It's just the people that are transgender or have a different gender identity than you may perceive them to be, will appreciate the fact that you took that time to ask that question. And similarly, then, when somebody is a gender minority, I would then oftentimes ask, which pronouns do you prefer that I use with you? And sometimes, I say he, him, his, her, hers, they, them, they, something else, and have them define that for me. It's just important to not make assumptions and go from and making sure that you're being appropriate. So. Looks like Adam is mentioning that a replay of this webinar will be available on the Facebook page once the live feed stops and Facebook processes that video. And again, my contact information, my email address is shown on the screen here. So happy to have questions by email as well. I don't know if Adam or Seth or others need to say anything else. Otherwise, we can close out, I think. I'm not hearing anybody else speaking, so I think we're probably all done. Thanks for coming, everyone. I hope this was useful, and have a great day.